The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. This month, we're talking to Dr. Lisa Palmieri, general pediatrician extraordinaire, and someone who has taken her interest in autism to the next level by getting training and by making a significant part of her practice diagnosis and treatment of kids with autism. Welcome back, Lisa.
Thank you so much. Happy to be here.
Is that a fair description of your practice?
Yes.
It's changing lives in every possible way?
Yes, in every possible way.
That's what we're all aiming for. Well, in the past week, have you developed any conflicts you'd like to disclose?
Alas, no.
Have you developed any conflicts that you don't want to talk about, but you probably ought to?
Alas, no.
All right.
The life of a boring frontline pediatrician.
Maybe so, but I think the hardest thing to establish of all is that I have no issues at all.
No issues, no conflicts.
Okay, let's move forward then. One of the things that we were talking after last week's session was we sort of touched on the idea of adaptive function, but could you define what adaptive function is?
So when I started doing some of the testing, adaptive function was the hardest term to get my mind around. Once I kind of heard it explained in a clearer way, it helped quite a bit. But it's how well can someone manage the things they need to do every day to survive and thrive. So these are everything from your activities of daily living to managing your clothing to getting along with people. And there are any number of different screeners that are used to define a child's adaptive function. But when you're talking about someone with autism, if they have very good adaptive function, the diagnosis is not as critical. You really want to get the diagnosis in someone whose adaptive function isn't good. So it might be the 18-year-old that can't learn to drive because they're so afraid and can't talk to anyone outside the family and can't take on a job and can't cook a meal and it's still being reminded to bathe. So that is what you would describe as poor adult adaptive function. And there are, again, any number of screeners, and being able to look through these screeners gives you an idea of what an adaptive function might be. One that I'm using is called the ABAS, ABAS, and that's one the schools will frequently use as well to define adaptive function. And so it really is the combination of the diagnosis of autism with showing that the child has adaptive function delay that gets the most support.
Very helpful. Okay, let's jump into the next age group. We talked last week about the toddlers, the preschoolers. We talked about the early schoolers. Let's talk about the elementary age now. So these are the kids, first grade and beyond. What should make me suspicious that these patients may have autism?
So there's quite a list because by now the child's lived enough years to start to develop a little bit of history. So I look at a child has a history of unmanageable aggression. So 6-year-olds are not hitting parents generally anymore or kicking holes in drywall, that kind of thing. The child for whom, as they get older, there is no management of their ADHD. So we know that neuroatypical children are exquisitely sensitive to medications. And if you're on medicine number 4 or 5 and they all have a bad side effect or do nothing, it may be that you're not actually treating ADHD alone. You may be treating autism with ADHD, or there may not be ADHD. So I tend to think of a highly drug resistant or sensitive child as someone I need to think about autism in. Severe social anxiety also is possibly on the spectrum, particularly if the child has any of the minor criteria. So if they're also extremely rigid or like to talk about only one thing, that child may not just have social anxiety, they may also have autism. I think the child that's repetitively bullied is one that would draw to mind. There's been some suggestion in a book that I read called Autism with Heels that in women there is a higher rate of social and sexual aggression against the autistic person. So a person who's had multiple aggressors may be having difficulty identifying pre-aggressive behavior and disengaging, or maybe odd enough or quirky enough that they are being singled out. I look for no invitations to birthday parties, no identifiable friends in the classroom. The parents can sometimes observe that the child, quote, stands out in the group. And interestingly enough, a prior diagnosis of ODD, oppositional defiant disorder. So, Primary Behavioral Health, which is Intermountain's behavioral health group at Primary Children's Hospital, no longer uses ODD as a diagnostic term, although some of the neuropsychologists within that group still do. And it's been my experience that ODD is really another term for autism spectrum disorder. So, there's some question about whether ODD is an appropriate diagnosis for a child. So it should be viewed with suspicion if it comes from somewhere else. Whether you believe in that diagnosis or not, you ought to at least ask yourself, is that really where the oppositionality is coming from?
Gotcha. So in this group, we talked about last time, there are more people to potentially collaborate with. The kids are functioning in other settings besides their family by this point. So it seems like it's important to communicate with the school about how the child's functioning there. How do I help families find a route to diagnosis at this age?
So that's, of course, the most challenging issue. The school will often have done some educational evaluation already. And so knowing what it is you're looking at in the school's testing is really helpful. So the first piece of information I look at in the school's testing is the child's cognitive evaluation, which is usually something called a WISC, WISC. Also, you can see a standard Binet or a Kaufman, but less so. And that number gives me a little bit of an idea of how much cognitive delay I'm dealing with to start with. We all know that people are not a number and that their cognitive abilities cannot be defined by a number. It is, however, a place to start. And unfortunately, it is a place to start for state funding as well in some situations. I also look for their adaptive score. That comes from the ABAS or something called a Vineland. And then you get the most information about what they're doing behaviorally from something called the BASC, BASC. And this is pretty standardly filled out both by the teacher and by the parent. And you can really see how much aggression, ADHD, depression, anxiety are being endorsed by both the family and the school. So sometimes that's a good place to get you started so you can see whether or not your suspicions are worth pushing this family forward. And then you have to just get in line and wait. Evaluations run anywhere from 4 to 8 hours with a psychologist. They will take some of the school testing, but often do it again or repeat or do their own. There just aren't enough school psychologists to go around. So we have a running list of who does these and who takes what insurance in our practice, and we try to keep it updated and refer. And I think the big mistake people make, parents and providers, is not getting in line for testing. So a year later, they say, I want the diagnosis, but we could have had it by now, but we didn't get in line.
How often is cost an obstacle?
Cost is a big obstacle. This can run in the thousands of dollars.
Yeah, it seems like a very unfair sort of obstacle too, because this family is going to be stressed on a lot of levels, just dealing with the sorts of challenges that come from social divergence and that sort of thing. And so it feels like we all ought to have a Sherpa who walks us through this. And I guess what you're arguing is that to some extent, that's what I'm supposed to be doing.
That's what I'm supposed to be doing. I'm the Sherpa that's going to walk you through this. And in the meantime, I'm going to be trying to deal with the behavioral issues, because a lot of times parents are okay waiting for the diagnosis if they can just get help with some of the behavioral things going on. And that's where I bring in our OT and our feeding therapy.
And you do that liberally, and you see that as an intervention already, right?
Right. And a lot of times the psychologist wants to see those other evaluations to define the extent of the sensory disorder or the feeding disorder. So they're not in silo with each other.
So we're dealing with sleep issues now.
Hmm.
Am I dealing with sleep issues differently than I would before?
So the first line medication is melatonin, and it has the best outcomes in autism spectrum and ADHD kids. And about one third, I think, of I may have that data wrong. I'm so bad with data. One third of people with autism have ADHD as well. So melatonin is your first line. Interestingly enough, I got a little tip from a sleep psychologist that you can give zero point 0.5 milligrams at dinner and have the child fall asleep at a normal time. And I found that successful in some cases. But as most pediatricians know, these children can be very sleep medication resistant. And so at this point, I'm bringing in trazodone, clonidine, and hydroxyzine. Hydroxyzine is not a preferred sleep medicine for our sleep colleagues because of its effect on REM sleeping. But I have some children, that's the only way we can sleep. The other thing is that every child seems to become adjusted to the sleep medication over time, and you have to go up on dose or change categories. So often I'll work through the trazodone levels and we'll be sleeping pretty well for a year and a half and then stop sleeping. And now I'm on clonidine and then I come back to trazodone. So I move back and forth between the medications once the child becomes habituated.
What about GI issues in this age group?
Constipation, again, is the most problematic, and it is particularly problematic if the child's toilet trained because the parent often doesn't know. So I find myself doing more KUBs than our GI colleagues would ever want us to do because we don't know what the stooling history is. And if the child is nonverbal, they can't or won't tell us. So I end up with dealing with that. And that is a big, constipation is one of our biggest, most common reasons for increasing aggression.
And frankly, can be difficult for parents to read as well, even though they
Oh,
know the
yes.
yeah.
And then also to treat because these children have a lot of sensory sensitivity in their mouth. So they often refuse the PEG or the Miralax in the water because they can taste the granular nature of it. So we end up trying everything from daily senna to fiber supplements to lactulose, whatever we can get in the child to help with the stooling.
Sure. Making school work is a big deal at this age, and educational accommodations. Tell me about educational accommodations and, just a note again about reading IEPs.
So I think that the SPED departments are doing really well trying to make educational accommodations for children on the spectrum. Your most aggressive nonverbal children are going to be in an accommodated core classroom or perhaps lower in an ECC. However, if they can do mainstream, they are really encouraged to do that. And the schools, I think, are working hard on accepting neurodiversity. I have one of my teenagers who's graduating this year who's on the cheerleading team. And he's clearly on the spectrum, but he's having a wonderful time on the cheerleading team. And it's not an adaptive cheerleading team. Other children are brought into the choir or band or art classes to blend more. And there's been a lot of encouragement of the neurotypical children to include these children in activities. So I think the schools are working hard toward that. There are schools in our area that are specific for children on the spectrum, specifically Spectrum Academy, which has two campuses, one in North Salt Lake and one down in Pleasant Grove.
Is there a general strategy to begin with more accommodative settings and then moving toward mainstream or early mainstreaming, or is there do you know if there's an educational theory about how that works best?
I don't know that, but I would say that it seems to be very kid to kid dependent. And I haven't found more than maybe one or two situations where the child was held in a class that was lower than his capability. Both of those were situations with children with very high IQs, but very big behavioral problems. And that can be very frustrating for those parents because the child is reading at a seventh grade level in the third grade, but still throwing desks. So.
What other resources are available for families? Because it's an issue that touches on families as well as on the patient.
So there are schools that incorporate ABA as part of their day, and that's always really nice for the patient because if you have a child who's going to do ABA after school, that child's been in school all day plus some hours of ABA, and it's a lot of intense interactional time in a child whose interactional cup is not very big to start with. So parents sometimes, if they haven't had a diagnosis before, aren't sure how to incorporate ABA into a child attending school. Sometimes they'll do it in the summer, the ABA in the summer, or they'll try to go to a school that incorporates ABA. Sometimes the child will have an ABA provider or an ABA called a BCBA attending school with them to kind of do the ABA alongside the child. There's a number of different peer social groups set up. We really like Lego League. It's a really good place for your higher functioning STEM interested child with autism to be able to work as part of a group. Easter Seals used to have a wonderful Lego Autism Social Club. I think that's not available anymore, but I would love it if they would get that started again. There is a social group called Peers, Peers, and that's been a real godsend for one of my patients who's made his super best friend there. And he's been attending this Peers group at the University of Utah for 4 or 5 years now. And it's a social skills training group, but it's also a place where they can make friends.
Let's talk a little bit about comorbid conditions in this age group because you've touched on these a little bit, but anxiety and ADHD are both quite prevalent in this population and maybe a little bit trickier to treat.
Again, because the children often are not good candidates for cognitive behavioral therapy, and because they are very, very sensitive to medications. So, if the rule of treatment on ADHD and anxiety are start low and go slow, and by low, we mean very low.
So you mean start lower and go slower?
Start lower and go slower. We're already low and slow in children in general, but a starting dose for Ritalin might be 5 milligrams or 2.5 milligrams. I'd be very wary of starting a child that I suspected of being on the spectrum, even if they didn't have a diagnosis, on a long-acting medicine right out of the gate, because sometimes that 5 milligrams will keep them up till midnight or 1 o'clock in the morning, given at 7 a.m. The two most common our best studied medications for the anxiety treatment are sertraline and Lexapro. And I have a colleague that starts at 6.25 milligrams of the sertraline. I tend to start at about 12.5 milligrams, and I haven't had any significant difficulties with that. That being said, one of our local psychiatrists feels like you need to really watch the stimulants, particularly for worsening aggression, around 6 weeks. I would say that I don't think that's across the board what I've seen in my practice, but I have seen it a couple of times where the aggression was definitely linked to the stimulant starting 6 weeks earlier.
Very helpful. You talked a little bit about screens last time. Screens begin to take on more of a dimension in school years.
Particularly when you're talking about safety and screens, because often for these children and young people, gaming is the social outlet. So I'm very hesitant to say, you can't play your game because that group of people online are the only friends this child has identified at all. And he finds these friendships through the game very fulfilling.
Mhm.
So that child does not want any more in real life friends. He's quite happy with the 5 or 6 people that he games with. But we know that predators will insert themselves into these gaming groups in order to try to manipulate the younger people in there. We give it a lot of kids who like to watch YouTube, and there's been some issues with pornography coming onto sites that children frequent. Parents, I'm surprised they seem now to know a lot more than I do about good blockers. So there's a number of new blockers I heard about even this last week that I wasn't aware of that would allow a parent to see what the child is doing or block certain content. But as fast as we find it, the predators seem to find their way around. And these kids are very particularly vulnerable to manipulation and abuse.
Anything else you want to say about this age group?
I think that we want to really focus in this age group on helping the child find a social group, particularly as you're looking toward the middle school years. I almost feel it's more important than their academics, which I realize will kind of make me the hated person from the school district. But I can get the child to go back through the academics, but trying to go back and fix the social isolation is much more difficult. So, particularly when you have a child with a special interest, if we can exploit that special interest in a social group, that's ideal. And I'd like to give a shout out here to a group called Motley Squad, and they're motleysquad.org, and that's Motley squad.org. This is a social group for teens and a separate one for young adults that does not have any social skills training involved in it. It's just for fun. And so they will go to Lagoon, they will go to the reservoir, they will go to boating, they have a winter ball, they have a prom. The motto is everybody's band of friends. It was started by my friend Miranda, whose son is on the spectrum, and he said, "Where are the people that are my friends?" to her when he was in middle school, and she started this group. I ended up becoming tangentially involved and got nominated to be president of the board, even though I have no board experience whatsoever. So this is a case of don't raise your hand. I really believe in what they're trying to do, and I know there's other places that are trying to do similar things in your area. So hooking families up with Facebook groups that you're aware of. And in our area, the big connection group is the Autism Council of Utah that will have events listed and social groups and other things kids can sign up for, as well as parent-to-parent support.
As kids transition into the middle school, so you touched on this a little bit, but I just wanted to expand on this. As kids head into middle school and high school, what are the things that change there that should change both the way I look at and evaluate kids, but also how I help them accommodate?
So, as we all know, puberty hormones are the death knell for all pediatricians with managing chronic diseases. Everything gets harder, from asthma to rheumatoid arthritis to autism gets more difficult with hormones. So, I try to prepare parents at ages 8 and 9 for when puberty comes, saying that what worked one week will probably not work the next. So, and that's the advantage I have as a primary care physician is that I'm a little more readily available. So if a medication regimen has suddenly, without any warning or any provocation, stopped working, I can go back and make a change pretty quickly. So I tell them we're going to be versatile, we're going to be flexible, and we're going to be making changes much more rapidly. I also really encourage parents before we try to fix it with a pill, what's going on environmentally, because often there is an issue that we can fix without having to fix it medically. So, this is again the review of systems, but for the environment as well as for the body. What's happening on the bus? What's happening in the family? What's happening with what in the child's bedroom? What's happening with peers? Has there been a new teacher? Is there a new person in the class? So sometimes a very minor change in the class, like arrival of a new student or the change of a teacher, can be enough to disrupt a kid and cause increased aggressions and symptoms, malfunctioning symptoms, much higher than you might think for that change.
How do you deal with some of the practical things like hygiene?
So, our good friends in the ABA world have taught us about social stories. And this is a really good thing to do if you have a patient that's afraid to see you. So, a social story is a set of pictures about what the child can expect or needs to accomplish. ABA works very classically on the idea of first we do this and then we get this, or first we do this and then we do this. So, an example might be a child is being checked into your office and he's walking down the hall yelling, "Park, park, park, park," because he doesn't want to be where you are. He wants to go outside and play. And so, even using this language, you're using the ABA language he's familiar with. First, we see the doctor, then we go to the park. And sometimes you have to break it down. First, we do the stethoscope, then you can spin on my stool. First, we do the ears, then you can scribble on the paper. So, understanding kind of first, then, and then having the parent use pictures to show the child what is going to happen. And the internet is full of these social stories, from everything from how to go on a date to how to brush your teeth to how to take a bath. And the parent will probably be using ABA language. First we brush our teeth, then we go to bed. So that first, then language.
Do the principles of ABA apply through high school into young adulthood?
Yes, and so I had initially understood that Medicaid only paid for ABA through age 8, but that's now no longer true. So if you can use ABA to help with any daily routine that the kid is struggling with, including hygiene, all the way up through age 18 now. And most insurance companies tend to follow what Medicaid does. So ABA can be good for a high-functioning, high IQ child who is struggling managing his hygiene.
And other things that are just...
And other things, yeah.
All right. Anything else you want to say about this age group?
I wanted to just again put a shout out to how it looks different in girls.
Yes, please.
So they often are not diagnosed as early. In fact, there's a pretty shameful history of a delay of diagnosis, both in girls and in people of color. And in girls, a lot of the intense interests tend to be normalized as girly. So if the girl is interested in unicorns, that's like, well, that's a girl interest. And so it's kind of normalized until the child gets to about 4th grade, when they still want to talk about unicorns and the other 4th grade girls do not. And they have more wide-ranging interests and they no longer want to focus on one thing. Girls are again socialized earlier and more social demands are placed on them. So the term that the autism community uses is masking. So these girls will often mask their autism symptoms, which means suppressing their behaviors that might look queer or autistic, such as flapping or spinning or hand spinning or echolalia, in order to gain acceptance. But it's at a huge cost to self-esteem and creates significant anxiety. So if you have a young woman who's got pretty intense interests and is highly anxious, you may want to think about autism in that setting. There's also a lot of school avoidance, both in boys and girls in this age. So the child that's not attending much school at all is probably going to have some autism spectrum issues.
That's helpful. Well, we'll talk some more about some of these related issues next week as well. There's a lot of stuff to talk about here, but I think this has been very helpful. Did you want to put in a pitch for the training program again?
Yes, it's through the University Developmental Assessment Center, and it is at aspire.hsc.utah.edu. And it's an asynchronous training, primarily geared for the diagnosis by pediatricians of 24 to 36-month-old children. And again, even if you don't decide that you want to make diagnosis part of your practice, attending the training will significantly improve your ability to recognize early presentations of autism that are less severe.
All right. Thank you, Lisa. We really appreciate your insight and your time. Those of you who have questions, please send your questions to questions@ecurb.com, and we'll talk about them in a couple of weeks. You willing to come back again next week, Lisa?
I think so. Sure, it's fun.
All right. Pace yourself. Thanks so much for your time, and we'll talk again next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Lisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.